Good morning, good evening, and good afternoon for all of our vascular surgeon and hematology family all over the universe. It's my great pleasure on behalf of the VOT board to welcome all of you to our 8th webinar meeting titled Varicose Vein Ablation and Cosmosis. Let me introduce my co-moderator, Dr. Omar Al-Farouk. Hello, Omar.
Hello, Professor Ayman.
And now let me introduce our great speakers, Professor Ahmet Kursat Buzkart from Turkey, Professor Pierluigi Antoniani from Italy, and Dr. Ashkan Hajansi from Emirates. Thank you. And let me welcome our great panel today. Dr. Bashir Osman from South Africa, Dr. Surat Timirov from Uzbekistan, Dr. Fabrico Santiago from Brazil, Dr. Murad Salam from United Kingdom, and we are waiting for Dr. Suat Dugansi from Turkey. Thank you for joining us, and let me introduce our first speaker, Professor Ahmet Kursat Buzkart. He's a professor of cardiovascular surgery, Istanbul University. Professor Ahmet started his training at Istanbul University and spent about 2 years in Castle Hill Hospital in the United Kingdom. He's a member and board holder of European Board of Thoracic and Vascular Surgery and fellow of International College of Angiology. He's the vice president and previous president of Turkish Society of Vascular Surgery and previous president of Asian Society of Vascular Surgery. Dr. Ahmet has a lot of publications and many chapter books of great influence. And let me say it is cited over than 300 times. Professor Ahmet Buzkart is going to discuss today the role of glue ablation, ANO 2020, question and answers. Please, Professor Ahmet.
I think I want to share my slides.
Yes, please.
I think Prime Voice should do something because it's writing host disabled here. I'm trying again. I think they should allow me to share my slides.
Mr. Khalid, can you help?
Is there something wrong here?
Check now, doctor, please.
Do you want me to try?
Yes, please try.
Hang on, sorry about that. We did check it previously.
Is it working now?
No. I think someone can start, and in the meantime, we can.
It's working. Dr. Ahmed, it's working. I can see your now we can see your desktop, Dr. Ahmed.
Can you? But I cannot see my slides. I'm sorry about that. Can you see my slides?
Dr. Ahmed, you have to open your slides first, please.
I did.
Okay, then please, when you press on share screen, okay, select the slides and open.
No, do genç.
Yes, it's ready. It is full screen here. Come back here. Share screen. Got it? Can you see it now?
Yes.
Yes, it's visible now.
Good. Right. Sorry about that. I mean, actually, we did check it previously, but sometimes it happens. First of all, thanks for the invitation. It's great to be here with you. My subject today is the role of glue ablation in 2020. There are some questions about that, and I'm going to answer to these questions as much as I can. First of all, we should talk about tumescent and non-tumescent techniques. I mean, we got laser and radiofrequency as tumescent techniques. They are good, they work, but there is a growing interest in the recent days regarding the non-tumescent techniques. Foam definitely is a very good choice. I've been using foam for a while, but remember, the results of the foam is at least 25% less than the other techniques. We have mocha, Clairvoyant, and phlebectatica. Maybe phlebectatica is what is a Polish-made mocha. It works. It's also nice. But my special interest is regarding cyanoacrylate glue. There are 3 companies currently producing glue. Venaseal is the original one. And in the last 6-7 years, we have 2 Turkish-made glues. One of them is Venablock, and the other one is varicose. Our experience is on both varicose and Venablock, which are Turkish-made glues. The first glue paper in the world appeared in 2015 in Journal of Vascular Surgery, and this is the first randomized controlled trial comparing glue versus radiofrequency ablation. And what they did is 200 patients, half glue, half radiofrequency ablation, and the results of glue ablation are as good as radiofrequency ablation. This is very important. As good as radiofrequency ablation, there's one advantage, less ecchymosis at the day 3. Recently, we have the 5 years results of this trial, and at 5 years, complete closure rates are 94 for glue and 91 for radiofrequency ablation. These long-term results did show glue works as good as radiofrequency ablation. The second paper following VCLOS trial in the world was our paper, which was published in 2016 in Journal of Phlebology. In this study, we compared glue versus laser ablation, not radiofrequency ablation. Half 300 patients, around 300 patients, half laser, half glue ablation. And you can easily see here, procedure was shorter, pain was less, ecchymosis was less in this series, in the glue patients. And more importantly, paresthesia rate was quite low in the glue ablation side. So it is an easy procedure. It's good for the patient. For the sake of the patient, it's definitely easy procedure. You can do it in an outpatient procedure. Even you can do this procedure in the lunchtime. It's very easy. But what about the closure data? Definitely the closure data is as good as laser ablation. There is no difference between 2 groups in terms of closure rates, as you can see in the left side. And regarding the post-procedure clinical assessment, VCSS and ABVQ data also did show similar results. The end of our study, what we did show is glue ablation is safe, as good as laser ablation, but in several points, patient has some more advantages, easier procedure when we are using glue ablation. In another hospital, we did another study. Actually, I didn't personally involve two these cases there. I helped them in the first cases, but then after that, they continued to do this procedure. It's almost the same protocol, laser versus glue ablation. It was some sort of control study in another hospital, and which was also published in Journal of Vascular Surgery, and the same results. I mean, the closure rates and quality of life data is as good as laser ablation, but the procedure was definitely easier than the thermal technique. Interestingly, an Italian group in 2019 collected the 7 studies published in the world literature. All of them were actually Turkish glue. The average procedure was only 11 minutes in this meta-analysis, and occlusion rate at 12 months and 30 months was really good, over 90%. That means in the medium term wise, the occlusion rates are quite good. Another Turkish paper, 2 years follow-up and almost 99% closure rate. It's a very good and interesting study, again from Turkey, with using Turkish glue, 3 groups, radiofrequency, glue, and laser ablation. And believe me, all of them are doing very good job in terms of closure. But at conclusion, they are saying glue appears superior with respect to peri-procedure pain, which is quite normal, return to work, and decreased VCSS scores. Before giving this lecture, I just made a literature search and I found a very brand new paper. It's a meta-analysis which was published in March 2020. I think the vascular surgery, venous and lymphatic disorders. Here, the authors made a systematic research regarding the glue. What they did see is they evaluated over 160 papers, but unfortunately, finally, they found only 3 studies which are suitable for quantitative meta-analysis. These are our study, 2016, this study which was published by Roland Yassim in 2018, and the closed trial. Unfortunately, there are only 3 well-designed. Actually, honestly speaking, our study was not controlled study. It is prospective study, but randomization was not blind. That's why we had some problems. But at the end of the day, there are 3 studies: the closed trial, Erolu trial, and our study. I mean, at the end of the day, both of the studies saying same closure rates, almost same quality of life data, but in terms of quality of life and other subjects, glue are doing better job. I mean, all of the slide says, for example, here in this slide, you can see closure rates are same. Glue versus laser, almost same. Ecchymosis rate, mostly in the VCLOS trial, is less in the glue group. Phlebitis rates high in the American series, low in the Turkish series. I will explain it later. And the other characters, as you can see here. Certainly, if we compare these 3 studies, phlebitis is, closure rates are okay, same. Phlebitis is slightly more in American series, ecchymosis in less, and DVT rates are quite similar in both studies. Last year, what we did is, on behalf of the European College of Phlebology, we prepared this guideline. It is really a collective work. Mostly myself and Lars Rasmussen worked on it, but it's a collective data, and we just try to do our best to prepare this guideline. What we did say in this guideline is, for the treatment of great saphenous vein and short saphenous vein, thermal techniques might be laser or radiofrequency has 1A recommendation, which is very important. MOCA 2BA. The reason is we got one data which was published 2 years back. Actually, after 3 years, the closure rates of MOCA is 83%, which is not satisfying. That's why currently we did suggest as 2BA. For the treatment of great saphenous vein reflux for cyanobilate ablation, we choose 2AA. You may ask me why not 1A? Because when we are writing this paper, 5 years data was not available. VCLOS trial was published, not published, actually presented recently, and that's why still we do see 2AA is the recommendation for. Certainly, there are some questions which should be answered regarding to, first of all, long-term data. Do we have enough data? Yes. For American glue, Venaseal, we have 5 years data, which is enough. But for Turkish data, I'm going to present our 5 years data in next year, and it's going to be interesting publish. There are phlebitis problems, granuloma problems, and long stump problems with using glue. I want to answer these questions. First of all, in American series, or in Venaseal series actually, phlebitis is a big problem. In Turkish series, it's only 4.5%. Why? I don't know 100% what's the reason, but definitely definition of the phlebitis might be a problem. Maybe the composition of the Turkish glue is different. Yes, it is different, but at the end of the day, this is N-butyrosinacrylate. Continuous, we are using continuous delivery when we are using Turkish glue. Maybe between the drops, when we are using Venaseal, we are leaving some gaps here. It may cause some sort of phlebitic reaction here. When you are using Turkish glue like that, it's a smooth application. Maybe this is the problem, or possibly it's only a definition problem of phlebitis. There is a big rumors regarding the granuloma formation after glue ablation. I've seen one picture of a patient from Slovakia with granuloma formation. I saw these pictures, but this patient has underlying different problems. That's why it's not easy to explain this granuloma mutation in those patients from Slovakia. But there are some questions regarding the late granuloma formation after glue ablation. In our country, we've been using this glue for 6-7 years now. I mean, my experience is thousands, maybe. But overall experience in our country and in other countries is over 150,000 cases. So far, there is no reported granuloma with using Turkish glue. But definitely, I have to admit, we long-term follow-up for these patients. But now, currently, we haven't seen in this country any granuloma formation after this procedure. My concern, my special concern, my private concern for long-term wise is long stump. When we are doing laser ablation or radiofrequency ablation, what we usually like to do is we like to be close as much as we can to the saphenofemoral junction. We are not leaving anymore 2 centimeters stump here. We like to be as close as possible to here. And this is very big advantage because in this way, we are closing down the orifice of the anterior accessory saphenous vein. I did the first case in 2005, maybe 16 years now. The main reason recurrence in my cases are from anterior accessory saphenous vein. I'm not doing any recanalization of the great saphenous vein. Mostly, I did so far 7,000 applications, and most recurrences are coming from here. If we leave a long segment here, for example, the Venaseal suggests 5 centimeters, it's too long. It may cause a big problem, and you may end up with a big recurrences. That's why currently, I like to be close as much as I can to the saphenous junction. definitely to protect deep system is very important. And I like to be almost 2 centimeters to the saphenopharyngeal junction when I am using Turkish glue. The difference between Turkish and American glue is the polymerization of Turkish glue is very short. It's in 5 seconds. That's why usually deep vein thrombosis or thrombus emboli to the lung is not a major problem. So in the long-term mice, my great concern regarding the glue ablation is this long stump business. You may ask me one question: has superficial venous management already moved away from the thermal techniques? For example, Dr. Bosco, ablation in your experience? No, it's definitely not. In the first decade after the millennium, we used mostly laser. Second millennium, laser and radiofrequency. And definitely third millennium will be thermal ablation techniques plus laser, radiofrequency. Definitely glue and MOCA will be a great role for the treatment. A special note for short saphenous vein. Still, I do maybe in 60 to 70% of the patients thermal ablation. If I'm doing great saphenous vein ablation. Again, if I'm doing great saphenous vein ablation, I still do on 70% of the patients thermal ablation. But if we are talking about short saphenous vein, I do mostly glue ablation because it's very easy procedure, and in order to avoid any neurological complications, which might be a problem for thermal ablation techniques, I mostly use glue ablation for short saphenous vein, and specifically for short saphenous vein, the future seems one of the non-thermal techniques. Just I'm going to give some very short data regarding our experience with perforating vein closure with glue as well. Actually, Erwin described first this procedure. Then we did around 50 cases. It's very easy procedure. As you can see here, there's a perforating vein here, perforating vein here. We are putting a small 16-gauge cannula to the perforating vein. You can see here very nicely. Then introducing the tip of the catheter to the, just level to the fascia, then blocking it with glue ablation. It works. Our closure rate at 6 months was low at the beginning, but now it's getting better. And ulcer healing rate is definitely very good. And as you can see, AVVQ data also shows very good improvement of perforating vein ablation. I routinely do perforating ablation with glue now in most patients. So glue ablation of incompetent perforating veins is feasible, easy, and safe technique. And finally, thanks for listening to me. And I want you all to see in the European College of Phlebology World Congress, which is going to be in Istanbul at the end of September. And another news, European Society of Vascular Surgery will be in Istanbul in 2023. I want to see you all in Istanbul in these occasions. Thanks for listening to me.
Thank you, Dr. Ahmed. It was very nice talk. I enjoyed it definitely, and I think all the attendees and the panel enjoyed it very much. And I think there'll be some interaction will start just now. Let me welcome Dr. Kabnik from United States and Dr. Suad Dugansi from Turkey and Dr. Murad Salam. They joined us, and of course my dear friend Dr. Tara Abdelazim. Happy to meet you all, and let's start our discussion. Let me ask Dr. Fabrico from Brazil. What's the situation in Brazil using the glue? What's your impression of glue in Brazil?
No, actually, we don't have glue here yet available. So in terms of practice, we have no experience. We have some experience watching some colleagues around the world and regarding the papers that are published. So in terms of practice, I have no experience. But I'd like to ask a question to Dr. Ahmed. We have some publications regarding phlebitis-like reactions just like an allergic reaction. Don't you have experience with that in your daily practice?
No, we do. We do have. For example, 5 to 6% of the patients, we do have this kind of reactions, but certainly it's not as high as the Venaseal. I mean, it's okay. We can say at the end of the day, it's a cyanoacrylate. It's some sort of allergic stuff. It's Japanese glue, but it's not quite often. So in none of the patients, we have seen any major problems.
What's the percentage of this kind of complication that you have in your practice?
5%.
Okay.
45. But it's not a serious. It's just a mild problem.
Okay.
Okay, thank you. Dr. Surat from Uzbekistan. What's your experience for glue in Uzbekistan, dear professor? Dr. Surat?
You need to open your mic. Yes.
Can you hear me?
Yes.
Thank you for presentation, Dr. Ahmad. It was a great presentation, but unfortunately we don't have experience with glue. I wanted to ask some questions about glue. Is there any limitation about diameter of vein? What do you think?
In our protocol, we used so far it was 16 millimeters, 1/6. But if you ask me personally, what do you do in your daily practice? I like to go to laser radiofrequency if the size of the vein is over 12 millimeters. So as protocol, yes, you can use 16 millimeters, but practically speaking, if the size of the vein is 12 millimeters, I like to do radiofrequency ablation. Just I want to say, any doctor, any phlebologist, any vascular surgeon should have 2 tools together, one thermal, one non-thermal. Non-thermal maybe mocha foam, doesn't matter, but thermal ablation definitely has a very important role for the treatment of truncal ablation. So I'm using, for example, in 70% of the patients, I do use thermal ablation. In 30% of the patients, I like to use glue ablation. I'm not using mocha at all.
Okay, thank you.
Okay, let's.
Second question is though, what about cost effectiveness? So it does matter for our country. Which one is what cheaper?
In my country, the price is almost same now because we are using Turkish glue. I mean, we have a full reimbursement in our country. The price is definitely lower than Venaseal. In this country, I mean, the difference is maybe 20%. Glue is 20% more than thermal ablation techniques. But I know for Venaseal, it's much more expensive than laser radiofrequency ablation. So in our country, it's not a problem because we have a full reimbursement and the price is not so high than laser ablation.
Thank you
Great.
again.
Let's have another voice from Ankara. Dr. Suat, what is the situation in Ankara? Do you have a great experience with glue too, with Turkish glue?
Actually, I think after Dr. Kürşat Bozkurt, it's not possible to talk about glue because he is the most experienced man in Turkey and in many of the other countries. So he is doing a lot with this. But in Turkey, it's very, especially the Turkish glue, is a commonly used technique now, and many of our colleagues are using Turkish glue with good results. But in my experience, I mainly use the thermal techniques, and I'm preferring to use laser in many of my patients. So I don't have that much experience to talk about glue therapy.
But just I want to ask you one thing. You have a very good study for the short saphenous vein in comparison to the lower cannulation, higher cannulation. What's your experience of the neurological problems after laser ablation for short saphenous vein?
Actually, thank you for the question. After publishing this article, we, I think, mainly never go down below. So we are cannulating the small saphenous vein at the mid-calf level, and after this, we didn't see that much neurological complications. And I think we are also doing good tumescent technique by using the duplex ultrasound. So we are caring about the nerves. So with the thermal technique, and we are also, for many years, we are using the lower energy and joule with the laser ablation when we are doing the small saphenous vein. So we are not seeing that much problem with the thermal techniques.
Yes, you have a point. Let me ask Dr. Lowell Kapnick from United States. Dr. Lowell, do you think there is a chance for glue versus laser?
So in the United States, the mainstay of therapy is still thermal. The insurance companies are mediocre in terms of responding to them. Our social or Medicare population are available to glue. They are reimbursing. I just wanted to thank Professor Bozkurt, because he was instrumental in teaching me about Turkish glue and had the ability to actually participate in some cases. And I've had the experience of using cyanoacrylate in the US as well. Don't ask me which one's better. I'm relying on Professor Bozkurt with the decreased amount of phlebitis, as well as so far no cases of granuloma. I do have one question for Professor Bozkurt. When you do non-thermal cases, do you stage your phlebectomy, or do you do phlebectomy at the same time?
It depends on the patient, Dr. Kapnick. I mean, if it's a private patient, and if the patient comes from another city or another country, I like to finish everything in one session. So in the private patients, I'd like to do everything in one session, and which works very nicely. But if I'm doing a case in a government hospital in which I can recall the patient and I can easily do, yes, in the government patients, I do stage procedure. I do truncal ablation, wait 3 months, then call it back. And both of them works.
So if you would tell me, for me, when I do non-thermals, I stage all my phlebectomies, because it doesn't make sense, because one of the advantages of doing non-thermal is that you don't need tumescent anesthesia. So I guess it really depends on your patient. If they're pushing to have everything done at one time, and you're still going to use local anesthesia, I'm in a quandary. The other last question to you is, how many different types of glue are there in Turkey?
Basically 2. Both of them are actually the same glue material. But the difference is the application system. In one of them, it's totally Seldinger method, the catheters and everything. The other one is like a radiofrequency catheter. So there are two companies producing glue, but at the end of the glue itself is almost similar.
Thank you very much.
My pleasure, sir.
I think Dr. Bashir Osman has a question. Please, Dr. Bashir, open your mic. Dr. Bashir, do you hear me?
Thank you, Prof. Ahmed, for this enlightening presentation. I don't have actually personally much of experience with glue, although I'm aware that there are few centers here in South Africa that are using it. It's clear that now it is almost works similar to thermal ablation techniques, with the advantages of less pain, less damage to nerve, and all the advantages that you have mentioned. I just want to ask about, I want to refer to Prof. Mark Whiteley on work on transmural apoptosis and ultimate fibrosis and disappearance of the vein. Do you have any, or are you aware of any studies that are explaining the exact mechanism or the exact pathological change of the ablated vein using glue?
Yes, there are a lot of microscopic studies. It's some sort of granulomatous reaction. I mean, you are just, you are not cooking anything there. You are causing a giant cell granulomatous reaction, which ends with fibrosis. So it's totally chemical thing. For example, glue is actually working for AV aneurysm, arteriovenous malformations in the brain in the same technique. For gastric bleeding is the same technique. So it is a granulomatous reaction ending up with the fibrosis of the vein and closes totally the vein. There are a lot of microscopic data on it.
I have one more question, if I may. Professor Bozkurt, at 4 years, do you still see cyanoacrylate in the vein with Turkish glue?
Yes, we do. It's a permanent stuff. I mean, at the beginning, we were thinking after 1 or 2 years, it's going, but it's not. After 4 years, 5 years, still I can see the glue there. I have one patient, which is very important. I have to tell something about this patient. It's not my patient. In another hospital, they put the tip of the catheter in the popliteal vein. The glue itself is actually inside the popliteal vein, 1.5 centimeters, but it's not embolizing to anywhere. After 3 years, I'm controlling this patient. The glue is still there. So if we do speak with the patients, we have to say to the patients, it is a permanent stuff. It's not a absorbable stuff.
Thank you.
I would like to ask a question, if it's possible.
Yes, yes, you can go ahead. Your mic, you need to open your mic, Professor Ayman.
I'm sorry. Dr. Tariq Abdelazim, do you have a comment for glue and its use in ablating varicose veins?
Yeah, thank you, Ayman, and thank you for the nice presentation, Dr. Ahmed. Like most of the speakers, the panelists, we don't have, again, practical experience with this technique. But I was just wondering, you showed us some nice slides about injecting the perforators, and I was concerned about the risk of extension into the deep veins, particularly as you just mentioned that this glue will last for years inside the vein, so it's not going to recanalize if you block the deep veins. Have you seen any problems with that?
No, we haven't seen. The technique is very important. First of all, if you are using Turkish glue, the difference between American glue is the polymerization time is very, very quick. Believe me, it's very quick. So if you are staying just in the fascia level, and if you are injection very slowly at the beginning, 0.2 mils of glue, then pulling the tip of the catheter slightly back and another 0.2, I haven't seen any deep vein thrombosis problem here. But definitely experience is very important here. So far in the maybe 100 cases, I haven't seen any major problem here. But on the other hand, we are talking about cocket perforating something like that. I haven't seen any, but if one of the deep veins here blocks, nothing happens to the patient because it's very small vein, you know, it's a duplicate veins there, it's not causing any problem. So yes, it's a possibility, but I haven't seen any so far.
Thank you.
Okay, now I leave the mic for Omar because I see many questions, and the mic is yours, Omar, now.
Okay, thank you very much. Thank you for the great presentation, Professor Ahmed. The first question comes from Dr. Omar Adahlan. He said, does the Turkish glue have FDA approval?
No, not yet. No, not yet. The company is working on it, but not yet.
Okay. Another question. Are the glue granuloma is a problem with Turkish product as Venaseal? Is the same problem?
No, we haven't seen any case so far. It is a very, very small possibility. Yes, we know it, but we haven't seen. I mean, I'm always checking, but we haven't seen any.
Okay. And another question from Dr. Haydar Aslan. He said, good evening, Professor Ahmed. How can you solve the complication of phlebitis? Which medicine do you use? And how to resolve the problem? I think he said, do you use corticosteroids or not in these situations?
No, we haven't seen any corticosteroid. We haven't seen any serious problems so far. In my experience, I've seen only one patient which might have some sort of allergic problem. I did the procedure. After 4 years, the patient developed temperature, but which is 40 degrees Celsius. It was not easy to explain this situation with infection. This is the only problem so far I have seen. I haven't seen corticosteroids. We are just giving some anti-allergic drugs, very simple, very easily.
Okay. I would like to welcome Professor Rag from Germany. He has just joined our panelists. Welcome. One of the last questions regarding Turkish glue. Can you use Turkish glue bilateral on the same session? You can use it on both legs?
No, you cannot, because as I told you before, the polymerization is very quick. You don't have enough time to use for another leg. So if you are going to trade one for one leg, the other one is the other leg. Practically, you cannot.
Okay. Now, the last question I will take from the attendee. There is Dr. Mohammed, who has raised his hand. If we can open his mic, he can introduce himself and ask the question. Now the mic is open to you, Dr. Mohammed. Okay, can you ask your question, Dr. Mohammed? Okay, it seems there is a problem with his mic. So with that, I have taken all the attendee and the question.
So maybe while we are waiting, I could have asked a question?
Yes, please.
Okay. Thank you, Professor Ahmed, for your nice lecture. I'm, as usual, was interested in your explanation of the anterior accessory great saphenous vein, which was a cause of recurrence, as you explained. Do you check the accessory anterior and see if they have a reflux before performing the glue ablation for the great saphenous vein, or no, you just close it, and that's in case that they are having the same orifice or they're starting from one joint and they are not separate?
No, I'm just putting the tip of the catheter around 2.5 to the saphenofemoral junction, and in many cases, actually, I'm blocking the orifice of the anterior accessory saphenous vein. I'm not, for example, making the difference. There is a recurrence, stay closing. If there's a recurrence, no, I'm just closing it, because my great concern regarding the long-term wise is a recurrence from anterior accessory saphenous vein, like laser, like radiofrequency ablation.
But that's in case if the accessory saphenous vein is starting from the great saphenous vein. But if the anterior accessory saphenous vein is starting from the common femoral vein, what do you do about that? And if that vein is having a reflux?
In that case, I usually like to go foam for this case. Very occasionally, if there's a big vein, I can use with separate cannulation, glue ablation there as well. You can do it, but as a separate procedure.
Okay. And I can take the opinion of Professor Rugg, yes, about Germany. What is your verdict about glue?
Although I missed most of the presentation, I'm well familiar with former presentations. Thank you so much for this contribution. We should notice that all the current glues have a nice advantage. It closes the vein immediately and shrinks it to a permanently small diameter, but it's at this time an almost permanent implant. So I would say every gluing at this time is an intermittent stage of a promising method. We have to learn, but industry has to supply bioresorbable glues, which is not easy. And there are lots of things to improve. And this is just a nice phase of learning for all of us. It's not the time to talk about perfection or anything like that, but we are on the way. So this is my German experience with every kind of glues which are there in the world. We also have our own developments with light activating glues and so on, but it's just the way we are on all together.
Yeah, okay. And let me welcome Professor Murad Salam, consultant vascular surgeon from Guy's and St. Thomas's Hospital. Do you like to add a comment about using glue, Dr. Murad? You can open your mic.
Not really. I don't have much experience with glue. I've used it, but I echo the last comment that I think that it's still a bit early for the glue development, and probably there is some more work for it to become more used as a replacement to other strategies. But personally, I have learned from the lecture earlier, and I've not used it much in my practice. I use the thermal ablation and foam much more.
Do you use glue for endo leaks, for example, closing lumbar arteries during aortic surgery? I know you have a big practice of aortic surgery.
Yeah, we usually would use coils and onyx,
Okay.
the main ones that we would use for embolization for endo leaks.
Okay. Okay, with that, I would have finished discussion for the first lecture, and the mic is back to you, Professor Ayman.
Thank you, Omar. Thank you, Dr. Ahmed. It was very nice presentation and very nice interaction. We all enjoy that so much. It's good to welcome Dr. Chris Ragg and Murad Salam. Welcome on board. Now, I'm very pleased to introduce the great Professor Pierluigi Antoniani. He's a professor of angiology from Italy. He is a director of Vascular Center, Nova Villa Claudia, Rome, Italy, and president of Italian Vascular Foundation, and general secretary of Union Internationale de Phlebologie, and vice president of International Union of Angiology. He's honorary president of Italian Society for Vascular Investigations. Dr. Luigi Antoniani is going to discuss today Corona Phlebotica UIP guidelines. Please, Dr. Antoniani, go ahead.
Thank you for the kind invitation. And I try to share my Is okay?
Yes, it's okay.
Perfect. Well, why we speak about the Corona phlebectatica is a particular sign of a chronic venous disease. For a lot of time, we don't consider this a particular sign, but in the last years, we emphasize this condition, and we conclude that it's very important to define the evolution of the chronic venous disease. The corona is defined as a fan-shaped pattern of bluish intradermal veins with a diameter less than 3 millimeters on the medial or lateral aspect of ankle and foot in the inframalleolar area. The corona effectively was described some time ago by van der Molen as an association of cup-shaped dilatation, intradermal telangiectasia, and stasis spots in the paraplantaris area. you can see in the slide the typical position of corona phlebectatica. You can see here the vein, a presence of capillary dilatation. Here there is the red or blue venules and telangiectasias, and in the other part there is the capillaries, and we define the stasis spots. To observe the corona phlebectatica, we have to define this area of the foot, and we have two areas. The most important is this. The other is the other part, anterior part of the foot. This is the cutaneous area where the sign, where the sign of corona should be looked for. The definition of corona phlebectatica was used in the Venaseal study by Widmer as the definition of the first grade of chronic venous insufficiency. However, it was not taken into account in the first CEAP classifications because its clinical significance was disputed in 1994 when was created the CEAP classification. In the 2004 revision of the CEAP classification, the corona was mentioned and defined as I proposed before, fan-shaped pattern of a numerous ball intradermal vein or medial or lateral aspect of ankle and foot, commonly thought to be an early sign of advanced venous disease. So it is important to define this condition to lie the corona to advanced venous disease, but is not included in the classification mainly because of the absence of clear-cut practical diagnostic criteria. The diagnostic criteria for corona is very important, and using the CEAP classification C classes, the evolution of the information linked to each of the 3 items of corona show that the stasis spots are the most specific severity marker, red intradermal venules the most sensitive one, and the blue intradermal veins the most reproducible. The combination of these 3 items was very important. In the study, we evaluate on 100 photographs by 6 experts, and we define the presence of corona and its characteristics. The consensus for significant alteration being at least 5 non-confluent bluish intradermal veins. And on the basis of this study, we ask to put the corona into the C4 class. Finally, in the 2012, we published the consensus of International Union of Phlebology on corona phlebectatica, reporting all study and the correct definition. The diagnostic criteria of corona is more than 5 non-confluent intradermal veins, the presence of a stasis spot, extension equal or superior to half length of the foot, the tiny areas of perivenous pigmentation. This is very important for the definition. Here there is reported the study, a statistical study, to correlate the different clinical class of CEAP classification with the corona. And you can see this is very important, the connection between the most important C classes of CEAP classification, C4, C5, and C6, for all 3 items of corona. The same is reported in this other graphic. The stasis spots and the blue telangiectasias are very clearly associated with the ascending order of the C classes. More is the evolution of chronic venous disease, more is the presence of corona in the patients. And we define a different recommendation, the two grades of severity of corona. The incipient corona, in which there is more than 5 clusters of oblong intradermal vein in the submalleolar area, and the definitive corona, or grade 2, in which there is the tortuous bluish intradermal vein with a diameter less than 3 millimeters in submalleolar area, extended over the half length of the foot or more. So not limited, but extending. This is some example of different stage of corona phlebectatica. You can see here patient with the telangiectasia of foot, but is no corona. This is the first grade of corona phlebectatica. This is the second grade 2 of corona phlebectatica, the more serious condition. The evidence. Also in the basal venous study, corona was shown by far the best predictor of subsequent occurrence of skin changes in the subject with mild disease of mild chronic venous disease. In large case control study on the risk factor for leg ulceration, the corona was found to be the second best independent predictor after the presence of skin changes. This is very important. In the second study, bone vein study, the corona grade 2 was associated with the C3, C4, whereas the corona grade 1 was equally distributed in all C stages. For this conclusion, sometimes the corona was considered such as telangiectasia and defined as C1. But the clinical data from a series of a lot of patients evaluated by 50 venous specialists demonstrated a statistical association between corona and the more advanced C clinical class. A pattern of blue telangiectasia consistent with the corona has also been found to have a good sensitivity, 91, but a marginal specificity, 52%, for advanced venous disease. So the characteristics of a corona are the more than 5 non-confluent intradermal vein, the presence of stasis spot, extension equal or superior to half length of the foot, and thin areas of perivenous pigmentation. This is the proposed diagnostic criteria accepted also for the international consensus. And the new position on corona, the patient with the corona has been demonstrated to be 5.3 times more likely to develop an ulcer, a risk of similar magnitude to other C4 skin changes. To account for this association of corona with a more advanced venous disease, the designation of corona was C4A in the new classification. And finally, in this year, when was published the revision of CEAP classification, you can see the position of corona as C4A. Before, the pigmentation or eczema, defined C4B, and lipodermatosclerosis or atrophy blanche, C4C. Finally, the corona was considered in the CEAP classification after 20 years around. So, for the panelists and the audience, we can start with the discussion. Do you know the corona phlebectatica? Do you observe the corona, and is it simple or not to identify the presence of corona in your patients? And you see the correlation between corona and the stage of chronic venous disease? Please, Ayman, if you manage the discussion, and then I continue my presentation.
Yes, we can go on, but we don't have polling, so we can't use this question to see how many people will reply. That's the
No,
main.
is a question for panelists. There is some panel. Rag.
Okay, let's start by Rag. What do you know about corona, Rag?
We have a problem with the definition, as like all the other criteria from CEAP, it comes by watching. And in this very nice presentation, we saw a multitude of venous changes at the surface in the ankle region, but not all of these were corona phlebectatica. We saw spider veins. We saw enlarged veins of the sole of the foot. So my suggestion is, of course, we have to learn to identify these typical enlarged veins in the ankle region. But the true identification is by ultrasound. If I had a drawboard, I would show you there are multiple enlarged smaller veins which are usually not even visible. These are enlarged from below 1 millimeter to 2, 3, 4, 5 millimeters in the subcutaneous tissue around or going along with the saphenous vein or with perforators, but it's a crowd of enlarged vessels. So the recognition is very, very typical in ultrasound, and also to discern them from spider veins or enlarged foot veins. We see this almost every day, and the problem is not to recognize, but the problem is how to treat it. Usually you care about all the larger lesions first, and then take the corona as a sign of venous improvement. So it's fun to hear this presentation, and congratulations for that.
Lowell, do you have a comment about corona? Lowell, please.
Yes, we originally, and we don't go back 20 years in terms of that, we knew the definition, we understood, but we didn't understand the significance. And as was pointed out, that there's a significant incidence of venous ulcers associated. And I, like Chris, think that this is a sign, not a problem, but a sign of venous hypertension. And the question is, what is the etiology of this venous hypertension? And Chris, I think you're onto something, that if we reduce the venous hypertension, will indeed we be able to change the CEAP classification of 4A, which is corona, down to something else, which up until now we've not been able to reduce once it gets to like 4B. It'll be interesting to see.
My question to you is, have you ever seen corona phlebectatica without any other damage of saphenous or perforator veins? Yes or no?
No.
No.
That's what I say.
Great.
No.
Let's
Yes,
go back
okay.
to Dr. Antoniani and see what's going in the second part of the presentation.
Yes, I almost finished. How to treat the corona? I discussed in the discussion emerged this problem. Of course, the first is the treatment of chronic venous disease, because the basal venous hypertension is very important, and we have to treat to eliminate this hypertension. So the classic treatment of chronic venous disease by surgery, sclerotherapy, elastic stocking, and so on. But it's very important for the local treatment. The foam sclerotherapy is possible to treat locally when I eliminate the cause of the corona and the other sign of chronic venous disease. I cannot treat only the corona without treat the chronic pathology on the basis of the. This is very important. And of course, it is important to follow the corona to evaluate the evolution of stage of the chronic venous disease. In conclusion, the take-home message is the diagnostic of corona is determined by the presence of blue telangiectasias below the malleolar areas or stasis spot. Corona is associated with the presence of incompetent leg perforator and saphenous reflux, characteristic of an important venous stasis, venous hypertension, due to high predictive value for the occurrence of skin changes. A careful examination of the ankle is mandatory in any patient with the chronic venous disease, but mainly in the patient with more severe stage of chronic venous disease. Is a strong clinical predictor of chronic venous disease, is a high significant clinical sign, and there is a prognostic value for the progression of chronic venous disease. This is very important. So the corona should be evaluated in every patient with chronic venous disease. I think for this reason, finally, it has been considered for inclusion in the new CEAP classification. Thank you for your attention, and I invite all of you to take part of virtual congress, World Congress of International Angiology. We start in 15th of June with the open the Congress for 3 months. If you can access, is welcome. Thank you very much.
Thank you, Professor Ottoniani. It is very nice and illustrative as usual. But let me ask you, as we know, the direction of flow in the foot differs from direction of venous flow in the other limb. In the other limb, the flow goes from the superficial to the deep system in the lower limb, which is different in the foot.
Yes.
Does this change the treatment policy for corona?
No, we know that the flow go from deep to superficial area in the foot, such as in the hand, is the similar condition. But regarding the treatment, I think is no problem for this, because of course I have treat the patient with the general situation, and then at the secondary point I treat the telangiectasia in the spot in the foot.
Okay, I think Dr. Kanata have a question.
Oh, Victor.
Hi.
Hi.
Yeah, I still owe you my presentation. I will cover that stuff over this weekend. I will send it to you for the UIA.
Okay.
It will be a great meeting besides the trouble that we have with the coronavirus. I start working already. Everything is setting up. We have to move on and put behind the COVID. This is the idea. My question is like this. I've been seeing in those corona patients, if you be careful with your sonogram and just give a little more time, you will see so many small perforator veins that they're coming around. Are any of you treat them? Do you recommend to treat those perforators that we saw over there? And what is your final point when you see so many that kind of a problem in the patient who has corona?
But the corona is a sign of hypertension in the venous system. So, of course, I have to treat the cause of hypertension. So I eliminate the reflux, I eliminate the incompetent perforator, and then I treat the corona, because sometimes I obtain with the general treatment the reduction of the corona. So it is a sign of good results of the general treatment. It is very important.
This was my idea.
It's not aesthetic treatment. The corona is a clinical problem, and we have to use this as a sign of evolution, positive or negative evolution of a chronic venous disease, and treat consequently.
Do we have any other comments from any of you? Because my idea was the same that PL has. I will just start, because I have so many patients with that kind of trouble. I just figured out over the last few years that if I solve first the perforator vein and then go to the veins that they have around, the results are much better and the people just are getting away of that trouble without big trouble. What, do you have any other guy who is doing the same that I've been doing over here in Paraguay?
I actually disagree with you.
I agree, yes. Please, please.
I actually disagree with him because I think if the patient would come, that will be part of my lecture, with a complaint of the look of the corona phlebectatica, and you start treating them, you will leave the underlying disease, which will not be treated, and then it will end up with a big disaster. So wait for my poll on the next lecture.
Okay, fine. We will wait for it.
Okay, thank you, Ashkan. I would like to ask Professor Fabrico. Dr. Fabrico, what do you do in Brazil?
Hi, very nice presentation, Professor Pierre. Actually, it's I'm going to respond this question by asking Professor Pierre, because Professor, do you stage the treatments when you have an association of a superficial venous insufficiency, for an example, from a great saphenous vein first, and then after how long do you treat the corona? And this is because probably what we are going to do here. So we first treat the hypertension,
Yes.
sometimes in a one single stage treatment, but we usually wait some time, 2 or 3 months, so that the corona reduces a little bit. And what is your preferred method to treat those telangiectasias after you treated the superficial venous hypertension?
Yes, I agree. We treat before the saphenous reflux or the other condition of insufficiency of the system. And after, yes, 3 or 6 bounds, we observe the patient and we define what is the evolution of corona, because sometimes we have the reduction of these little veins, and so I treat only the presence of the other residual vein. But we wait some time to treat.
Do you treat it with liquid or foam?
I treat by foam because I am a angiologist, no surgery, so I have experience with the foam.
Yes, but with liquid sclerotherapy or foam?
No, foam
okay.
therapy.
Okay.
Okay. Now
Dr.
foam.
Dr. Tara Abdelazim from Egypt. I think you see many cases of corona in your practice. How do you usually manage these cases?
Well, I think the message has been clear that these are not just simple spider veins or superficial varicose veins, but they're just a marker for underlying more significant disease. And you just have to look at it that way. I don't think you should just go straight for the cosmetic part of the problem. I think you should treat the underlying problem first, whether it's superficial venous reflux or perforator reflux. And then, as Dr. Luigi just outlined, 3 or 4 months later, deal with the cosmetic problem of the corona phlebectatica.
Now let's go to the laser man, Dr. Swat. Do you use laser for treating corona?
Dr. Ayman, I think it was a very good question. Yeah, actually, I generally agree with all of the colleagues, because I think before treating the underlying pathology, you cannot do or deal with such type of, let's say, corona phlebectatica. But I think since we also talk about these cosmetic or aesthetic phlebological issues last week also, I think before treating the underlying pathology, it's not good to do anything. But after doing the underlying pathology, yeah, you can do it with foam or liquid sclerotherapy. And for the residual parts, maybe you can combine it with transdermal laser or transdermal radiofrequency. But I think the main thing is it will be a complementary work on it. If you can do it as much as with sclerotherapy, and then you can add some additional laser or transdermal radiofrequency, whatever you choose. I think it will be a complete therapy by this way.
Yes. My message is the corona is not a cosmetic problem, such as the telangiectasia of other parts of the lower limbs. The corona is an index of evolution of chronic venous disease. And if we follow the evolution of corona, we define the evolution of stage of chronic venous disease. This is a definition. So I have to treat, of course, the chronic venous disease, so eliminate the reflux, eliminate the hypertension in all conditions, in the saphenous vein, and the collateral vein, and the perforated vein. And then after sometimes, when I observe the results of the first treatment, I can treat the corona. In this case, is a cosmetic treatment, but I eliminate the cause of corona before.
Dr. Timirov, what do you do in Uzbekistan?
Actually, absolutely, I agree with Professor Pirlugi. So first thing we should be in Uzbekistan, we should eliminate reflux from great saphenous or from some perforates. Then, actually, in 1 month, we do foam sclerotherapy for corona phlebectatica. So that's why I'm absolutely agree with Professor Pirlugi. Thank you.
Thank you.
Dr. Murad from United Kingdom. Dr. Murad Salam, I know you are our aortic surgeon, but I think you see many cases of corona during examining patients. What do you advise them, or what do you do for these patients in your practice?
Yeah, I mean, I kind of I do a varicose veins practice as well, by the way, and I actually do agree with most of the comments. For me, it's a sign of an underlying disease, and it means further investigation, mainly a good quality duplex. And I never approach them without having full investigation and clinical assessment for patients. And I hardly treat them without picking or finding out what's the underlying cause, whether it's a perforated or a truncal reflux or varicoses. And then if they need any adjunct treatment, in addition to treating the underlying venous hypertension cause or reflux from superficial venous disease, then I would add extra treatment for that if required, which is basically pretty much what's been said already. So I don't think I have any different practice in that. It's always been, to me, even with the NICE guidelines and with some restricted practice of varicose veins in the NHS for a period of time, it's always been to me that those veins are markers of an underlying problem and they should not be ignored. And I have to say the practice in the NHS as well is changing slightly, from waiting into severe varicose veins disease and symptoms before you intervene into a less strict criteria based on the evidence that early signs usually signify an underlying disease.
Great.
I agree with Rag and the other. Of course, the ultrasound evaluation is mandatory in these patients. It's not without discussion. The complete evaluation of patients is mandatory. It's not possible to treat the patient without a good mapping, venous mapping or venous ultrasound evaluation. This is no discussion on this.
Yes, I agree too. And before I leave the mic for Omar, let us hear the last comment from Dr. Osman from Pretoria, South Africa.
Yeah, thank you, and I enjoyed the presentation. I think the consensus here is very clear that this is a predictor, it's a sign of underlying disease. And in my practice, I always look for proliferator or the chronic or the great saphenous vein hypertension or reflux, and I start by treating that first, and then my follow-up after 6 weeks, I would look for the remnant or whatever left behind, and then I will use liquid sclerotherapy for that. And I must say that actually with that actually I have good results. So I think this lecture is very good actually in highlighting this as a priority, that when we see something like that, always look for the underlying pathology. Thank you.
Yes, you can use the corona as a parameter to evaluate the evolution of the treatment, the results of the treatments, of course.
Now we are back to you, Omar. Please go and see what you have for from the participants.
Okay, thank you, Professor Pierre, for a great lecture. We have a few questions from the attendee. The first question from Dr. Omar Ad-Dahan. Dear Dr. Pierre, is the presence of corona phlebetica require adding daflon to the treatment? Daflon is a drug of micronized diazine.
Purified fraction, yes.
Yes.
Of course, it's important because it's one of the important treatment of chronic venous disease. It's very useful to reduce the hypertension, to reduce the endothelial damage.
Okay. The second question from Professor Ufuk Domiklik. I had a question about the therapy of foam. Is it safe in that area, especially in presence of pigmentation and ulceration?
It's difficult to treat the patient with the pigmentation of ulcers, but it's normal for the specialist to have attention to this treatment. Probably in some cases in which there is a very big ulceration, is not possible to treat, but is not the main goal of our treatment to treat the corona. We have to treat before the ulcers and the causes of the ulcers.
Okay. Another question from Dr. Haitham Muhammad Sayed. He said, can corona induce ulceration? And how can we differentiate between vasculitis as an ulcer and corona phlebetica?
But I repeat, we have to evaluate completely the patients with the clinical approach and the ultrasound evaluation, and then define the condition, the clinical and the hemodynamic condition, and then I decide what method I use to treat these patients.
Okay. The last question from the attendee. If a patient has only corona or spider varicosity, would you like to offer him EVLA, endovenous laser ablation, in case of competent saphenofemoral junction?
If you wish to use the endo laser for the treatment of corona, I don't agree, of course. I agree for the use of a laser for the treatment of the cause of corona, of treat the chronic venous disease, these causes.
Okay, and thank you very much for such a great lecture, for sharing it with us. And the mic is back to you, Professor Ayman.
Thank you, Omar. Thank you, Professor Niani. You are great as usual. Thank you for presentation, interaction. Thank you very much. It is very hot topic and you can manage very clear. Thank you very much. Now I'm pleased to introduce my dear friend, Professor Ashkan Haq Shams. He's a senior vascular consultant and head of department of vascular surgery department in Venaseal Hospital for Advanced Surgery. He is a fellow of Royal College of Surgeons, Ireland, and he is going to discuss cosmetic result of varicose veins treatment. Please, Dr. Ashkan.
Hi, everyone. Thank you, Professor Ayman, for the nice introduction and your nice lecture. Of course, unfortunately, this subject has been tackled a lot in the past lectures, so I was trying to imagine something to bring to the table. So let me try. Okay. We mainly talk about the outcome of the treatment, and we don't pay a lot of attention to the detail of the patient which are coming to the cosmetic treatment. So as we know, it's very important to pay attention to the details because, as we say, the devil lies in the detail. Cosmetic treatment of veins, it was not my major interest. And actually a friend of mine, Professor Kazum Miyake, he's the one who tried to excite me about treatment because I was always trying to save the limb, save the leg, and do the vein treatment. But what is the trick? When we look at the recent activities which happens in my vein clinic in my hospital, almost 60% of the patients who are attending the clinic are mainly talking about the visible veins that is bothering them, but not paying attention at all to any sign and symptoms. The interesting part of my patient or where I'm living in is kind of different than all around the world, because it's not only the mixture, the heavy mixture of different nationality, but we have mainly young generation. So the age of the population in UAE is mainly below 65. So since 80% of the population are expatriate, and expatriate are working in UAE to up to 65. So we have all young generation people, active, healthy, more or less, we can say, yeah? So rarely they come with complaints. But what happens is that most of these patients are visiting in the clinic on a first visit. And when we go through symptoms one by one, and I keep on asking them, and usually they deny and they say, we have none of these. They have to come one more time for their ultrasound investigation, which is done by me. And then most of these patients, they tend to specify that, doctor, most of those questions that you asked me, I started to pay attention to, and I found out that I have those symptoms. So this is one thing which I wanted to bring to attention of everyone, that it's not always the complaint that the patient come in with, it's the lack of knowledge of patient or not knowing the symptoms that they have and they've been ignoring it. So for this, I prepared a poll. So let's see what's the answer of everyone in this question. So do we perform ultrasound investigation for every patient who comes with a complaint, cosmetic purely, no medical complaint? Only they came to the clinic for a cosmetic reason and they want our assessment. So do we perform an ultrasound or no?
Please submit your answer. Can we get results, Mr. Khalid?
Okay, it's interesting, 16% no and 23% sometimes. Yeah, okay. Within my practice, practically I refuse to treat any patient cosmetically if I don't perform ultrasound, because I can't guarantee the outcome of my work. But it's the choice. And of course, the financial aspect of this question also matters. But we have to pay into consideration that at the end of the day, if the problem comes back, that would cost the patient much more. So here comes the next question. We have the second poll. Now, if we perform the ultrasound investigation and then we find out that there is an incompetent vein, so either the whole saphenous vein, great saphenous vein is completely incompetent or only partially, there's a segment of reflex at the area of the complaint. Do we treat it or we don't? So the emphasis is on asymptomatic. The answer is almost the same on the previous one. So we have more careful doctors than the more active ones. Okay, so as I mentioned before, for me, it's a basic practice that I never treat a cosmetic patient if I find a reflex underneath, because for me, the end result is more important and I don't want to further on face the return, because unfortunately, the patient have very short memory, and if they will have a recurrent of their condition again, they will come and say, but you did the treatment and it didn't work out, but they will never admit that they refused the proper treatment. So that's one of the things that we learn. So for me to start the cosmetic treatment of veins, I was taught by Professor Kazumiyaki that the best thing that you can do is photo documentation, or taking a lot of pictures. At the beginning, I was very lazy, but then later on, I understood that it's what saves lives and saves your practice, because most of the patient will forget how the leg was looking like. Of course, we will never remember. I don't know who has such good memory to remember how was the leg of the patient when he came to you first time. So as long as we don't have a proper photo documentation and we don't unify the method of our work to have similar pictures so we could compare before and after, we won't be able to practice cosmetic treatment at all. Of course, most part of our work in a cosmetic field is conversation with the patient to understand their expectation, to limit their expectation and to level their expectation to the reality. Furthermore, money talks. As we come back, and if let's say we treat the patient, we sort out the medical condition, we need to do the cosmetic, and the cosmetic is not covered by the insurance. So in this case, the patient who's paying for it, we have to consider their financial ability. And here I have a different opinion with our friend Kazumiyaki, because he is working on one method and he insists that he should treat the patient only with the top range method, but not everyone can afford the top range method, or they are ready to pay that amount of money for a problem that they think is not a life-threatening. And mainly they cannot show to others that they've spent too much money. In other cosmetic areas, they are ready to pay because other people will see it easier and they could show off. So how do I treat? Of course, we approach multiple methods. So if we have large varicose veins, my method of choice is mini phlebectomy. If we are talking about reticular veins, which is above 3 millimeter, 3 millimeter. So again, this is another question which we have to take into consideration, but is the diameter of the reticular veins. If we are performing the ultrasound in a time that it's cold, there might be vasospasmic, so we don't see the real diameter and it could be confusing. So usually I say between 2 to 3 to 4 millimeter, it's more safe to perform sclerotherapy. And if we are doing below 3 or 2 to the telangiectasic area, that's the time that we could finish up with the CLACS, which is the top of the range method, which we will be talking about, or it was talked about also before. So if we go with phlebectomy, of course, Varadi technique and the local anesthesia, and again, patients are different. So some patients we have to give them a little bit of mild sedation, but it's a day case surgery with minimum amount of bleeding, and they walk out immediately. And the result is very satisfactory for them. And this is within a month result. The next, when we'll talk about is the sclerotherapy. So for sclerotherapy, I use multiple techniques. I use sclerotizing agent. I use foam sclerotizing agent. Sometimes I mix this couple of substances to reach the optimal result. My method, my main trial to get the best result of my sclerotherapy is applying a compression treatment and keeping it for 2 weeks at least to avoid the entrapment syndrome, because that's the biggest problem that I've been facing at the beginning, which a lot of hyperpigmentation would appear, or we have to evacuate the hematoma continuously. But if I could manage to apply a proper compression unfortunately, in 50 degrees centigrade for 2 weeks, we don't have hyperpigmentation almost in any cases. And this is a very fast result and good result with any hyperpigmentation. As you can see in this kind of skin, I was expecting that there would be. And this location is very unpleasant place because at that time, in that area, the bandages usually slide and we always end up with a sliding bandage, but still the result was very good with her. Furthermore comes the technique which was invented again by Professor Kazuo Miyake in Brazil, which is called CLACS, cryolaser cryosclerotherapy. It's a combination of 2 week method to get the highest result. Of course, one of the biggest problem of CLACS is high investment, which you have to invest. And when you invest, you have to get the outcome of it. So the price of the procedure will be high. Depends on the patient. For some patients, it's kind of painful. They can't tolerate. Of course, we have different kind of patients. Some they are enjoying the process and they're sitting and they're working on their mobile with no complaint, but some they do complain about the pain, and we end up giving them some sedative medication or gas or some tablets, because that's done in the office and not in the operation theater. It's time consuming, but the good thing is there's no limitation for what we can do. We can sit hours and hours and do all the leg in one session. And one of the challenges I had is on some patients, since we are using cryo, so the cooling system, they are having very strong vasospasmic reflex, and in result, all the spider veins and reticular veins, they disappear and you cannot see them to be able to inject them or treat them. So that's one of the challenges that we have, not on all the patients, but on some of the patients, it's very excessive. So as you can see, the method is very simple. It's thoughtful. We hit the vein on a stage to make them weaken and get some vasospasm into the vein. And you can see that in the vein, the result of laser shots gives you vasospasm, which is visible in this case. And then it's followed by an injection of the sclerotizing agent, which here is glucose 75%. And you can see that the flow is not that fast as we are used to in the other methods because of the vasospasm, but it's very, very effective. And you can see here in this case, the patient is playing with her mobile while we are treating her, and she received lots of shots, as you can see here. But as per her, she's happy. And that's a result of one session even. So thank you for your attention. And if there's any question, I'm ready to answer.
Thank you, Ashkan. It was great presentation and great result. Thank you. And now I think we have many comments. Let us start by dear friend and dearest professor, Dr. Aaron Tonder from Netherlands. Dr. Aaron, please have a comment for cosmetic results of treating varicose veins.
Well, Dr. Ashkan, great presentation. Thank you very much. I enjoyed it. I can say, and I think all the panelists would agree, that the cosmetic patients are the worst patients to have when it comes to venous disease. And I agree with you that you should always take pictures before and after. Otherwise, you will have endless discussions about what you've been doing. And I'm just interesting to find out. It's just interesting to say, as you would suggest, giving all new patients that are visiting you for the first time a complete ultrasound examination. And where do you start? Do you start up at the abdominal region? Do you exclude deep venous pathology? Because we are finding and discovering throughout the past years that there are hidden, unknown, underlying diseases. Would you suggest starting an abdominal scan and then going down towards the legs and then start looking at all these very small, even as you know, even before it turns out to be a corona phlebectatica, as we discussed earlier, that you might even see these small spider veins, and actually it could have a deeper hidden reason for this. What do you think, Dr. Ashkan?
Yeah, thank you for your question. No, unfortunately, I don't start from the abdomen. It's a little bit excessive. We didn't have that much cases that with no symptoms, and as I said, asymptomatic, to have some abdominal issue. I usually start with the groins from the saphenofemoral junction, and I do thoroughly go through all the veins, as you said, even to the smallest reticular veins, and I do mark them furthermore before the operation. So that's how I approach the investigation.
Okay, let us go to Brazil. Dr. Fabrico, what do you think about cosmosis in the varicose vein?
Actually, this is a problem because in Brazil, many of our patients come to the office specifically because of cosmetic complaints. And Ashkan gladly mentioned the photographic importance. And I'd like to remind you that I have published in phlebology a very nice paper that you need to mention. It was published in 2017 online and 2018 paper regarding the differences between time. This is that there's a scientific explanation for that. It's called a subjective similarity. Physicians or patients, they do not remember regarding differences in time, the aspects of the leg. So you need to take pictures. If you would like to read this paper, which was published in phlebology, I will be happy to share with you. So regarding the ultrasound, the only problem with the question was every, because sometimes we have some pathologies just like essential lower limb telangiectasias that we usually treat with light sources as laser, that we usually do not have to use ultrasound investigation to do it. So it's very specific. The patients come to our office with those lots of tiny telangiectasias, the red ones. They are spread all over the lower limbs and sometimes concentrated. In these cases, especially if asymptomatic, we do not need to use ultrasound. But I would say that 99% of the patients, symptomatic or not, we usually do ultrasound. So, but Ashkan, I'd like to ask you something. Are you performing clocks in Dubai, but you're not using dextrose, right? What sclerosant agent are you using?
Thank you. I have to get your publication. If you wouldn't mind, send it to me. I will be glad to read it. Regarding the ultrasound, I go back to it and I said, no, I learned with my practice that I have to do the ultrasound. I have multiple patients. Almost 30% of the patients have no visible vein to the extent that you can't believe there's tiny, like 1 centimeter reticular vein. That's all what you can see on their leg. And you will end up finding that they have severe great saphenous vein insufficiency with large reflux. So with all the respect to everyone, I learned with mistakes, with practice, that I should do ultrasound for everyone, no matter what I see. Regarding the dextrose, thank God, after long fighting and a long time smuggling dextrose from Brazil, we managed to get the dextrose from Germany. The company are producing. It's not 75%, it's only 70%, but it does the job.
No, it's okay. Yes. Thank you very much. It was a nice presentation.
Okay, by the way, when we are talking Germany, Chris has a question. Chris?
I have 3 small remarks. So the German dextrose is equivalent to the Brazilian one. It's in addition very, very, very cheap. It's about €8 a liter, which will serve for, well, 1,000 patients maybe. So this is
don't have 1,000 patients. I have to drink it afterward.
but I have 3 serious remarks. First of all, what was really extraordinary of your presentation, it was balanced. It was not in any way doing advertisement for a specific method like we hear it so often. And thanks for that. That's unique in all of your presentations. Second, You know, I like to mention ultrasound. We learned not just to examine the whole leg, we also learned to determine the source of the particular problem. And this is different from what we learned, because in the spider veins, you usually will not see something we call reflux. Sometimes you will identify a root, sometimes not. So that's very, very tricky. But I think it's an area we should investigate in and should learn how little we can do to solve the problem. Sometimes if you just close the root or the 2 or 3 roots with microfoam, for instance, you will have a 90% nice result and have just a little bit to do for the perfection. So it's worthwhile doing ultrasound on these tiny lesions. You need frequencies above 16 megahertz. Okay, and congratulations for the results. Carry on.
Thank
you. Come back to cosmosis in treatment. What do you do, Swat, in answering this balance? Swat, are you still?
Thank you, Dr. Ayman. Actually, I want to come from Dr. Rex's comment to continue on the discussion, because duplex is very crucial. And also Erwin also mentioned about doing, let's say, duplex ultrasonography from starting from the abdominal part. But, you know, sometimes even you don't find some, let's say, reflux at the axial veins like the greater saphenous vein or the small saphenous vein. And when you see a lot of reticular veins in the leg, if you do a good duplex around that reticular vein, you are always finding some feeder vein or a larger, a big vein, which let's say causing those reticular veins. And that's why it's very important to look for not only the axial veins, but to look for in detailed way to see what was causing those reticular veins around that area, because it's a specific part of the leg that you see a lot of reticular veins, but in the other parts you don't see. So just looking for the axial veins is not enough. You should, I think, look for the around of that reticular veins, and if you find some, let's say, larger vein, which are the cause of that reticular vein, sometimes, as Dr. Reg explained, when you close that larger vein, you make a deep impact on the, let's say, disappearance of those veins. And it's I think, very important. So without making any detailed examination, just treating one vein is not a good thing. And this is what I want to emphasize on. And also the main problem, again, this, I think we shouldn't discriminate the therapies from each other, because every therapy is needed at one segment of the vein, and then you need some extra complementary therapy to complete your whole therapy. So I think we shouldn't discuss on which is better or which one is good than the other one, and we should combine all therapies to have an optimal result. This is what I want to mention on.
Great. Let me ask Dr. Murad from United Kingdom. As you told me, you do varicose veins. What about cosmosis? Do you follow these patients and do some? Do you get some cosmetic results for following them up, dear Professor Murad?
I think Dr. Murad has been called because he's on call today on Guy's and St. Thomas's. So he's not with us now.
Yes, I noticed. I'm sorry. Okay, let us ask Dr. Tariq Abdulazim.
Again, thank you for a very nice presentation. I just really have a comment, you know, with the techniques like CLACS and other thermal techniques coming into practice. We are now seeing more and more the so-called cosmetic phlebology clinics that are not really run by vascular surgeons, but by dermatologists and sometimes plastic surgeons. And their argument is you don't really need to be a vascular surgeon to deal with that stuff. I don't know if you have a similar problem in your practice.
Ashkan?
Yeah, actually, that's a fact. As you know, in many countries around the world, they allow dermatologists to perform phlebology. And we know a lot of renowned professors who have a lot of publication are dermatologists. So we cannot limit them. But in reality, yes, it's the whole aim of my lecture, as I said. If you are able to perform all these steps, as I said, to perform proper ultrasound, not whatsoever that it's done in many places, unfortunately, and find out the disease and could manage, and you have enough treatment to treat it, it doesn't matter if you're a general surgeon or a dermatologist and you have the right to do it. But unfortunately, most of the people, they just attack the visible part of the vein and treat the cosmetic part without paying attention to the underlying problem. And as well, they don't treat the larger one, which is not visible to eye, and they are the feeder of those telangiectasic. End result, they will have worse and worse outcome and recurrence, and they end up with what we call it the matting, which are patches which looks like bruise and with no structure, because all the channels and all the waves of the vein is already blocked by different kind of treatment, which is like laser or injection of the spider veins, and it's more difficult to treat in this condition if they would have done the proper treatment of root treatment, of starting the root cause of the telangiectasia.
Dr. Victor from Paraguay, as you are one of the top leaders of CLACS, do you think the nature of
Ayman, this is a big issue that we start fighting regarding about. There is some spot for the cosmetic phlebology in the world. I think more than 60% of my patients over here are just people who suffer from cosmetic troubles. This is a part already of the phlebology that we're supposed to be covering with that. I don't think that the people who said that there is no way to, we have to put apart the cosmetic area in phlebology. It can be done just only for maybe some nurse or somebody else. I think we have to train them well. After you train them well, everybody will be able to set up everything and have a good practice with them. And also the area of aesthetic phlebology must be mastered by us, because the people in phlebology, they just choose whatever they like and they fix the trouble in the way that they like it. In the same way that we talked before, Cursat was telling us the truth. You have to master one non-thermal treatment in your office as well as one thermal treatment. And you let the patient choose what are the best for them and what is the choice that they will like to use. And in my office, I let them to use. I have everything set it up without trouble. I have very good results. The idea is to have everything, to know everything, and to have a very well people, well trained. And that's the reason, or the webinars, or the treatment, or meetings, are many of the stuff that we are doing is that to show to everybody else how is the good path for the phlebology, for the cosmetic phlebology, and for all the stuff that we have to deal in the daily basis in the phlebology area. Okay, this is my point of view.
Thank you for emphasizing these remarks. But back to my question, do you think the nature of sclerosant differ in doing CLACS? Do you use
I usually use the question. I saw that he was injecting foam. I have very good results also with foam, not with 50% or 75% of dextrose in the way that they have in Brazil. I use 0.25% of polydocanol as a foam, and I have very good results in CLACS too.
Without pigmentation?
Without pigmentation. You have to be sure that be aware of I work in a private service with self-pay people. If I'm in trouble, they will put me all over the news if they have some dark spot after I treat them. The first stuff that you have to learn in aesthetic phlebology, and you have to take a lot of pictures, and show them after and before, after and before, and before and after. And you get tired of them. The people still, and the ladies will still complain that you didn't let that tiny vein that is over there disappear from my leg. This is the funny idea. We have to make sure, take pictures and give them the best that we have in our office for the best results for the patient.
Thank you, Victor. Now back to Ashkan. Do you think the sclerosing material differ, Ashkan?
Of course they differ. We have on every method, if you will use only the dextrose for the larger vein, it will not give you effect. On CLACS, it's very good, but if you try to do only separate injection into the vein, you will not get the effect that you could get from the foam.
Great. Now I think we are in need to listen to Dr. Kapnick. Dr. Kapnick, please, we all waiting for your comment.
I think it's very interesting, and in the practices around the world, when we get into cosmetic phlebology, everybody thinks that their technique is the best. And I would submit that we've not done a randomized controlled trial comparing any of these techniques together. So I appreciate everybody standing up for their own technique and saying that they're the best. I would submit to you that nobody's better than, well, on this panel, nobody's better than anybody else. We might have a few more tricks, but I wanted to just bring up one comment. You know, we talked about the different practices of phlebology and the people that are involved in phlebology. And for me, if you know phlebology and you understand what it is that you're treating and you understand the pathophysiology and you have the ability to treat, I'm not sure it matters whether you're a dermatologist, a vascular surgeon, a general surgeon. But here in the United States, we kind of segment things, and there are some sclerotherapists, there are advanced nurse practitioners. And I would submit to you that those advanced nurse practitioners know the ins and outs of sclerotherapy, but do they know the rest? So there are some really good advanced practitioners, whether they be nurses or physician's assistants, that are just as committed as we are. So where do you draw that line? That's a rhetorical question. Thank you for the privilege.
Yeah, you have a point, sir. Let us go to South Africa. Dr. Bashir. Dr. Bashir.
You need to open the mic, Dr. Bashir.
Sorry. Thank you for the great lecture, Dr. Ashkan. And I just want to reemphasize all what have been said before, that the need for documentation, photo documentation, the need to manage expectations, and obviously the need to rule out underlying reflux disease. And after that, I think all the techniques are good, in good hands, and results actually more or less are similar. So thank you again for this good presentation.
Thank you.
I will get the last comment before leaving the mic. Dr. Surat, tell me what you are doing to keep the cosmosis in Uzbekistan.
Absolutely, I agree with all of the comments. So what about ultrasound? Ultrasound is main diagnostic tool, and that's why price of ultrasound is included in our clinic, or price of price of this consultation. That's why each session of sclerotherapy, we will make ultrasound, and we will check out which vein of is closed and which is left. Then again, we will close with sclerogenic agents. What about difference of sclerogenic agents? So if it is matter if you have all of sclerogenic agents under your hand. if you have only one sclerojet agents such as polydecanol in our country, so it does not matter. We can do only with polydecanol from sclerotherapy. So it's my comment. Thank you.
Dr. Ashkan?
Actually, you do with what you have. You are absolutely right. We also had the same story. We didn't have the dextrose. We had to bring it in. Then at time it disappeared, so I had to manage with the polydecanol. Then there was some time that we didn't have polydecanol. We had to manage with fibroven. So that's a real fact which we have to live with.
I have a final comment, Ayman.
Please go on.
Okay, I thought that there are so many questions regarding about pigmentation and how do we treat the veins with a small tiny vein and telangiectasias. The reason of the hyperpigmentation is just only one. It usually happens to the young phlebologists because they want to get rid of the veins as soon as you can, and you trying to use a strong amount and a lot of amount of foam or your whatever agent that you use, and you are using too much and too strong. If you want to have good results, just go with the slight one that you can, the small amount of the foam and a small amount of the presentation that you can have. Dilute it, dilute it, and dilute it. As much as you will be having a very good result with no pigmentation. If you are using a strong amount of foam and also like a 1, 2, or 3% as a foam and a large amount of the agent, you will be in trouble because it will be a very good, to have a very good result, you will be in trouble because that strong sclerosing agent will give it to you. Thrombus will give it to you, scleros will give it to you, matting, and will put you in trouble. And you have to thinking about when you are young, you have to be the best trying to reduce the amount of the sclerosing agent in your set of treatment of telangiectasic veins. This is the final idea.
Thank you, Victor. Now back to Omar. The mic is with you.
Okay, thank you very much. We did enjoy Professor Ashgan lecture. I'm sorry to keep you awake in the last fasting night of Ramadan. I have a few questions from the attendee. The first question from Dr. Jalal Abdul Hussein. He said, is there reported cases of recurrent spider telangiectasia after sclerotherapy? How to deal with it when you get a recurrence?
As I mentioned before, if you are only treating the visible telangiectasic veins that you see, you will have definitely recurrent. But if you treat the underlying reticular vein, which are feeders of this telangiectasic, and you make sure that they are closed, then your result is much more permanent. Of course, we cannot guarantee that there will not be new telangiectasic appearing in other places, but at least what you treated in that area will not recur so fast, but only if you treat the feeders.
Another question from Dr. Omar Ad-Dahlan. I think Professor Kanata touched this point. He said, Dr. Ashgan, if I face hyperpigmentation, shall I change the foam to liquid or go down with the sclerotherapy concentration? I think going with the concentration down is the answer.
It depends on which kind of pigmentation you're having. We definitely have two different types of pigmentation which happens to us. One is related to the entrapment syndrome, which you have blood clots, and that's the skin reaction to the blood clot. Then you have the skin reaction to the dead veins. There are two different things, and that comes different with the did you put a proper compression or did you use a very strong detergent? Furthermore, if you are using a large reticular vein, you cannot use liquid because it will not give you a result. So you have to go down with the concentration. There've been a lot of studies and publication, and before all of us, we were using more and more concentration, and slowly there was studies that showed that even with 0.25% of polydiconol, you're getting the same effect as if you're getting from 1%. So there is no need to use very high concentration. But if you are treating the telangiectasic vein, for those you don't have to use the foam, you can use the liquid and it will give you a good effect.
Okay. Do you like to add anything, Professor Kanata? Do you like to add any comment?
Little comment is like this: when you are young, you are trying to just get rid of the vein as soon as you can, and sometimes you didn't have enough time to just thinking that the patient will coming back. Our patients, our aesthetic patients, you have to set it up that they will be, and explain them that you will be having this trouble forever and ever, and they have to coming back every 2 or 3 times in a year to fix the vein that are coming out. This is the way that I've been working here. In Paraguay, we have 40 degrees always. This is some moment that we will have like a 5 days of just a little bit cold weather, but then the hot weather will coming back. The ladies are going to the beach and going to the pools and all over, and they like to just show their legs to everybody else. And the idea is, if you tell them that you're supposed to coming back very often to the office to fix them, they are more than aware that we're coming back, and you have to make sure that the patient is already happy with the result. This is the final idea. You have to go down with the amount and also with the strength of your sclerosing agent, and you will have a very good result, and the patient will be very happy with you always.
Okay. Another question to Professor Ashgan from Dr. Ayman Asser. He said, do you send your patient to a dermatologist after treating the venous hypertension in cases of C4, where they have a lot of choices to treat hyperpigmentation and bleaching? So do you send your patient to a dermatologist after treating, let us say, patient with C4, you treated his incompetence, do you send him to a dermatologist?
To be honest, if the patient was caring about the look, they wouldn't reach the C4 and ulcer. They would have come and checked. Those patients, they just want to get rid of their ulcer. Of course, if they're interested, I would send them, but definitely those won't be a patient. The patients who care about their look, they wouldn't reach the ulcer stage.
Yes, that's right. Another question from Dr. Haidar from Turkey. He said, is it right that a small vein problem under the skin accompanied with almost leg vein problem? If we correct the underlying, I mean the big veins, possibly superficial vein will disappear.
You see, of course, the underlying is affecting, and I always tell my patient that if you will do the medical part or the superficial veins are treated, they could be, and I specifically emphasize on could be an improvement, but not disappearing, because those veins will not disappear, only the supply of the overflow of the blood to those veins will drop, and then they will have an improvement in the cosmetic part of it, and they might be happy with the result. So to save their money, I tell them, please wait. And sometimes it's interesting, but we get a better result or improvement after 6 months, not even 2 or 3 months.
Okay, I can see Professor Victor Kanata is raising his hand. Do you like to add a comment, Victor?
No, my final comment is like this: those guys that they start doing and using the sclerosing agent, they have to just make sure that the people who is telling them how to use it is a master and somebody else who knows about everything. As Kursat said before, they have to know about physiology. They have to know what's going on down the skin. They have to be aware of the sonograph. It will help them to find everything. And also after this, they will be able to just fix whatever is going on already. This is the final idea. And then they have to go slow and easy. If they go slow and easy, they will have very good results. But it happens to us when we are young. We have to go strong and faster. I'm sorry, but this is the way that happened to us.
Okay. So thank you very much, Professor Ashgan. I agree with Professor Rugg. It was extremely well-balanced presentation that we haven't seen for a long time. It was honest and direct, and I think it was a good base for starting young vascular surgeon his venous practice. Thank you very much, and the mic is back to you, Professor Ayman.
Thank you, Omar. Thank you for all speakers and panelists. I think all of us enjoyed your company. I'd like to thank Professor Ahmed Buscart, Professor Pierluigi Antoniani, and Professor Ashkan Haqqashans. The great panel today, we have a great panel. I'd like to thank Tara Abdulazim, Shir Osman, Surat Timirov, Fabrico Santiago, Murad Salam, Suad Dogansi, Lowell Kapnik, Chris Rack, Victor Kanata, and my dearest friend, Erwin Tonder. Thank you all. Enjoyed your company all. Before I go, please, I remind you to mark your calendar for the great event for next Friday. Next Friday, we have a great webinar. We have a keynote lecture from Eduardo Ramasciotti talking about COVID-19 and thrombosis, very hot topic and very important challenge. We have a great debate. Mark Whitley is debating Homan Jolie. Let us see what will happen in this great debate between Mark Whitley and Homan Jolie. Please mark your calendar for next Friday and try to give us 2 hours to enjoy all of us your great discussion and interaction with the speakers. I would like to thank Prime Partner, the great company who helped us greatly to make this non-profit webinar program. And please enjoy the Eid, enjoy Eid al-Fitr, enjoy the festival, stay safe, and see you next Friday. Goodbye.
Thank you, everyone. Goodbye.
Mm.